All right, guys, we're going live with our medical referrals starting Monday, December 7th. We're going to be getting them from both Cabarrus and Stanley. So I wanted to spend a little bit of time going over some things today to kind of get everybody up to par on what we'll be doing. So the first thing we did is we created a flow chart to show how these referrals are going to come into the community paramedic division. So right now we are going to use the EMS CP email at stanleycountync.gov for both Atrium or for both Cabarrus and Stanley to send the referrals to us. We're going to start off with stroke referrals who are at a high risk for readmission back to the hospital. So some of the key things is that from Northeast, the people who are going to send us referrals are called navigators. And from Stanley, the people sending us the referrals are called discharge planners. And if we come over here, the referrals we get to this email are going to include the proposed discharge date. And kind of down this way, we're going to try to see these patients no greater than 48 hours after they're discharged. The discharge summary and demographic information are going to be able to be found in Care Connect, and we all have access to be able to look that up. So coming on down here during normal office hours and Annette is working, she is going to schedule the CP visits for the CPs. She's going to make phone calls, schedule the appointment, and add it to the CP calendar. After she does that, she's going to send the community paramedic who is working that day an email with information related to the appointment. If Annette's not on duty, if it's the weekend or a holiday, the community paramedic on duty is going to be responsible for setting that schedule. They'll do the same thing. They'll call the patient, schedule the appointment, and add it to the calendar. They will also be responsible for sending an email to that community paramedic informing them of the appointment. A little bit down below, the day before or the morning of the appointment, the community paramedic is going to need to call that patient just to verify the appointment and let them know that we're coming out. If they accept the appointment, we're going to go to the appointment. We're going to do our assessment. We're going to fill out all required paperwork, which I'll go over in a second. And some of that includes the home safety check, disease-specific assessment, our ESO ticket, and some other things. Once we are done with that visit, we're going to come back and we're going to upload all of our forms and our ESO ticket, and we're going to email those paperwork and forms back to the navigator or the discharge planner. I'm going to create a spreadsheet, and basically it's just going to say whether or not we made that visit or not. If they refuse to have an appointment, we're just going to document the refusal in the spreadsheet, and we're going to email the appropriate navigator or discharge planner of that outcome. Back down here, we're also going to be sending this paperwork to the patient's primary care physician as well. I forgot to add that in the flow chart. I will get it added, but it's something else that we're going to be doing. I plan on getting a folder holder or file holder for the wall, so that way all of our daily appointments will be in one spot and we won't have to go fishing around trying to find them in different spots in the office. Once we get out to the house, we're going to have a few different forms that we're going to fill out. The first one that we're going to fill out is going to be called the home safety checklist. Now, this is basically just going through and checking the house to make sure it's safe and habitable for the patient. And it's just checking boxes going down the row between the outside of the house, inside of the house, kitchen, bedroom, bathrooms, etc. Once we get down to here, if we click no on anything in the assessment, then we're going to follow up with some documentation right here and whether or not we are going to refer this patient to our social worker to follow up to perform a more detailed assessment and to make some recommendations. We also have a little spot down here for other resources and referrals that we could refer to ourselves without utilizing the social worker. but since that's her area of expertise, I expect her to be fairly busy with maintaining these psychosocial needs based off of this assessment. Once we finish this assessment, we're going to go to another assessment called the support evaluation. And the support evaluation is just another psychosocial needs assessment, just to make sure that the patient has adequate resources in the house and the best possible chance of having a good quality of life once they come home from the hospital. I would like to see a lot of these, if they're checked no, to be referred over to our social worker, because this is where she's going to do her best work. And if we do check no, the social worker will go out and perform a more detailed assessment related to the different boxes that are checked no. So, pretty easy evaluation form, and it's just hitting your check boxes yes or no. After we do that, we're going to get more into the medical side of things. And the first thing we're going to do is a med rec form. So we want to reconcile all of the patient's medications, and we want to base their medications off of the discharge summary that we pull up in Care Connect. When they go home from the hospital, the meds on the discharge summary are the only meds that they should be taking. So if we come down here, we do have a PCP place, we have a pharmacy place that we can put this information in, and we can scroll down and we can list all the medications that the patient is taking. If there is a discrepancy, we do need to let the navigator know, and we also need to let the primary care physician know, either by phone call and speak to their nurse, or send them a fax or an email. Missy's done a great job of reaching out to a lot of the doctor's offices that are local to the area and letting them know what we're doing. And I know that they are probably going to look forward to us following up with them, especially on something like this. Some of the things that we can do to better it or make it easier for the patient is offer suggestions like a medication box, to where they have the 7 days a week, AM, PM type thing, and help fill their medication box for them, or give them instructions on how to do that themselves. They also need to know why they're taking certain medications. So if you don't have the Hippocrates app on your cell phone, I'd suggest you download it, because if there's a medication that you run across that you don't know what it's for, you can plug it into Hippocrates real quick and it'll tell you exactly what it's for and why they should be taking it. But that's the MedRec form that goes back as well. And the final thing that we're doing is going to be the disease specific evaluation, which is right here. And this is for stroke and neuro patients coming back from either hospital. So it's a detailed assessment, and by the time we get out there, we ask these few basic questions, and we assess vital signs. We teach the patient and the family members about the FAST acronym, and we do a couple other in-home education and assessments. So if we go down here, we see that there are some interventions, and some of the interventions that we're doing are well within our protocol. We're allowed to do, and we're doing this to try to keep them from being readmitted for the same reason they were admitted to the hospital earlier. So if they have new neurodeficits, how bad are the deficits? How long have they been going on for? And we need to notify that navigator by phone or pager immediately, so that way we can get some online medical control, and see what we need to do, whether we should try to treat them at home or whether we need to have them taken back to the hospital via ambulance. If we come down here, we just look at a little bit of the other interventions that we can make. And come down here, if they do have abnormal vitals and new neurodeficits, there are some interventions we can do. We can obviously give D10 to the patients who are hypoglycemic and see if that helps their neurodeficits resolve. If they're hyperglycemic, blood sugar more than 250, we can give them 500 cc's of saline, give them a bolus, reassess their vital signs, and reassess their sugar. If they're hypotensive without hypoglycemia, we can give them a 500 milliliter bolus and have them lie down and see if that helps their vital signs resolve. And then if they are hypertensive, We need to notify the manager or the navigator immediately. I have a feeling that they're going to ask for them to be transported back to the hospital at that time. Once we get that done, we're going to fill all this out. We're going to sign it. We're going to incorporate a more in-depth neurological assessment. I'm looking for the best model that would fit our agency and our community paramedics. And once I find one and get it approved, we'll do some training on it. But we'll also be using the cardiac monitor pretty frequently and some other diagnostic tools. So just keep that in mind when you're doing your truck checks in the morning to make sure your monitor has batteries and make sure everything is working the way it's supposed to. Once we get all of these done, we're going to take them back to the office. We're going to scan everything in and we're going to email the specific navigator or discharge planner. And once I get a list put up, I will put a spreadsheet in the community paramedic drive with the contact of all the different navigators and planners and which area of medicine that they specialize in, whether it's stroke and neuro or cardiac or respiratory. We'll be taking on some septic patients here in the near future as well. Once we branch out from the stroke population, I'll do another little video on the other disease specific assessments that we will be doing and how to go about getting those to those navigators as well. I'll put all of these master forms on the community paramedic thumb drive and I will also email them out to everybody. But in the meantime, if anybody has any questions about anything, please don't hesitate to give me a call and I'll do everything I can to answer those questions for you. Thanks, guys.